new approach to pan-retinal photocoagulation based on the fact that the DRS protocol is too aggressive and leads to a lot of loss of vision and visual field. So, is it correct? Our first ring compared to the DRS pan-retinal photocoagulation is the DRS third ring. And I want to make sure you take it home because we do coalescent laser. We don't do scattered laser. And we start at the aura. We try never to leave one little space behind from the aura to the mid-periphery. And it's retinal ablation of non-perfused retina. Our second ring, it starts at the mid-periphery here, and the main goal is to get to the vortex veins, and then you stop there. And try not to do any more laser in your patient unless it's a very aggressive retinopathy, as I'm going to show to you. Our third ring, we almost never do it. And this third ring is the DRS first ring that we don't want never to be done. Whenever we need to extend it, we do it inferiorly, respecting at least 1.5 to 2 disc diameters from the arcades, the inferior arcades. So you can leave some visual field to your patient. Here is a very typical example of our daily basis pan-retinal photocoagulation treatment in Brazil or wherever. So you see here a very aggressive retinopathy, and none of these patients had intraocular drugs done during or after the treatment. So after treatment, this lady did very well, and his worst eye became his better eye, 20/25. And her best eye became her worst eye, 20/60. And keeping some visual field. Now, this guy, he was 16 years old when I started treating him, and he is a taxi driver. He is 28 years, he has 24 years of diabetes, type 1, and the final result is this, 20/25 and 20/30, with excellent, very little macular edema and very soft laser focal treatment. You see, he did preserve a good visual field, and the vitreous starts separating from the retina. If you do start your laser as the DRS tells you to do, the first ring at the posterior pole to the equator, you're going to have more vitreous adhesion and more macular edema, as Hilo Lewis did elegantly presented in '89. Now, something very amazing, after PRP was done, the ERG almost normal. In the multifocal ERG, he has a good fixation and has an excellent response to it. The second case, it's a policeman. We also perform external ring photocoagulation on him. That is our pan-retinal photocoagulation, preserving the equator and the posterior pole with a good visual field. Vitreous is separating, very little edema, and there is some loss of response in the ERG, but it's still a very good response for a PRP-treated eye. And the multifocal ERG is excellent with good fixation. Now I have a treat for you. I showed you diabetes type 1 with long-range follow-up without intraocular drugs. And now I have a type 2 diabetes treated as the DRS. With 30 years of follow-up, as you can see, the laser scars, they are expanding and coalescing in the most important area of his visual acuity. Besides his having 20/25 or 20/30 vision, his visual field is almost gone. No macular edema and no response to the ERG. And also the full field, no fixation. besides the good vision. So, with external ring photocoagulation, you can halt proliferative diabetic retinopathy. You can also probably induce vitreous separation due to the inflammation you provoke at the periphery, because the vitreous starts separating from the periphery to the posterior pole. And the last part that will separate naturally will be from the nerve. Central visual acuity, night vision will be more preserved. And macular edema didn't seem to be a problem. So further randomized studies will be needed to prove this to you. And I got to thank you for the opportunity.
Thank you very much for the presentation. Our comments from the floor. How many laser burns do you?
Oh, you're going to be impressed. I do at least 2,000 laser burns each section, but I don't respect the 250 microns from the DRS, because the green laser allow me to diminish the laser mark, and I can also diminish a lot the exposition time, and in light patients, I have no pain or very little pain. And that's the problem when we do CRP. So you can be very aggressive with periphery without pain, and the amazing thing is, I've been doing it for 16 years now. And the most amazing response is that the patient, whenever he comes back to you, he mentions his vision is improving, or the perception of his vision is improving. And differently from the DRS, every time they come back to you, they say their vision is not improving.
Have you, and this question could be goes to the previous speaker as well, have you made any estimates as to the sample size you will need in order to prove a better outcome with your technique than with the DRS technique?
Yes, a beautiful question. I'm sure we'll need at least a big number of patients to prove, because the DRS protocol has been doing, we have been doing the DRS since the late 70s. And I've learned it with Howie Schatz. And since I came back home, I told Howie, I'm going to change it. And I did change, and I have an enormous number of patients. And the beautiful part of it is that the response is a constant response to halting the neovascular proliferation, vitreous separation, that gets a lot easier for us as surgeons. That whenever you perform the external ring photocoagulation and you have some problems in terms of surgery, it really improves our time during surgery due to vitreous separation.
We had yesterday an excellent lecture of John Marshall on femtosecond laser, and his statement was that in this coming decade in laser surgery we will see more laser benefits from less laser energy.
Thank you.